Good morning, ladies and gentlemen. I'm Yanling Zheng, come from the First Affiliated Hospital, Sanying University. It's my honor to be here to share our experience about CUS in abdominal arterial disease. My topic is including the following contents. The first is the abdominal artery aneurysm. The second is abdominal aortic dissection. And the third is a post-operative follow-up of abdominal aortic aneurysm. As we know that the abdominal arterial aneurysm is usually defined as a diameter dilated increases of more than 50% than that of the normal part. And the ratio of male to female in patients is 10:3, especially for the smokers. The smoking is also significantly increased the risk for aneurysm rupture. And the abdominal aorta is broadly subdivided into suprarenal and infrarenal segments at the level of the renal arteries. And most of the abdominal aortic aneurysm is below the level of renal artery. For the abdominal artery aneurysm are most asymptomatic, and only about approximately 5% of patients are symptomatic, and the symptomatic always means surgery treatment. And the symptoms also include the pain, the abdominal distension, and discomfort. Patients with acute rupture presented with sudden severe pain in the back, accompanied by shock, and even died before the admission. When we're doing the diagnosis of abdominal aorta, it is more than the diameter is more than 1.5 times larger than that of the adjacent normal section, and the maximum diameter is larger than 3 centimeters. And also there's a local cyst dilation. For these patients, the arterial dilated, which has not yet reached the diagnostic criteria for aneurysm. Now let's see some cases. This is the 66 years old male patient. He has no symptomatic and found by physical examination. And we can see here this is a normal part, and here this is the dilated part, and we can see the thrombosis on this posterior wall, and here the celiac trunk, the superior mesenteric artery, and the renal artery can be seen clearly, and also the right renal artery is a little bit of narrow. And after the injection of the contrast agent, we can see the bubbles in the lumen of the aneurysm, and the margin is very clear, and also the thrombosis can be seen clearly. And the common celiac artery also can be seen. The thrombosis can be seen very clearly in front area of the wall. And also on the CTA picture, we can see here this is the right kidney, and also the artery is can be seen clearly, but this is the left one, and the right kidney can't be seen clear. And also the artery is here. It is the diameter is narrow. And after surgery, this is a DSA picture. After the surgery, we can see here the flow inside the artery is very smooth. Now let's see another case. This patient is a 71 years old male patient. He complained of edema of both lower limbs, and the maximum transverse size of the aorta is about nearly 6 centimeters, and we can see mixed echo area around the aneurysm. Now we can see here, this is the transverse scanning, and this is the arterial wall. Around here, we can see the wall is discontinued. This is the rupture area. and here is a hematoma around the aneurysm. But the patient didn't feel pain, only edema of both lower limbs. And here we can see the both common iliac artery are normal. And this is the left one, and this is the right one. This is the transverse scanning. After surgery, we can see the stent in this aneurysm, and we can see the stent, the bubbles in the stent, and the wall is very clear. And also in the hematoma, there's no bubbles inside. This is the CTA picture. We can see the stent on both sides, and in this aorta are very clear, and the flow inside the stent are very smooth. Also, this is the transverse scanning, and this is the hematoma. There's no bubbles outside the stent. And the second part is abdominal aorta dissection. As we know that the dissection means the middle layer of the artery wall is torn to form two true and false cavities. The direction and velocity of both flow in the true cavity and the false lumen can be different or the same. And the main clinical symptom is tearing pain. Now let's see a case. This is a 68-year-old male. He complained of abdominal pain for about 2 weeks. We can see here on this color Doppler picture, and this is the true lumen, and this is the false one. And we can see on this position, this is the transverse scanning. The direction on the true lumen and the false lumen are different. On different position, the lumen is different. So here you can see the true lumen is narrow, and the false one is bigger. Also, after inject the contrast agent, we can see the lumen clearly, and also we found the rupture position is at the beginning of the superior mesenteric artery. Is around here, and it is the same with the CTA scanning. The third part is a post-operative follow-up of the abdominal aorta. After open surgery of the aortic blood vessel transplant or endovascular repair, it has an important diagnostic value for the occurrence of artificial vessel and endoleak in the EVA. Whether there is a fresh bleeding in the hypoechoic and anechoic areas around the true cavity, it can be operated repeatedly to find the source of bleeding because the contrast agent is relatively safe and no nephrotoxicity. Now let's see a case. This is a 53-year-old female. Before surgery, the tumor is about nearly 10 centimeters. 2 weeks later, he came to us for the uro surveillance. After the injection of the bubbles, we can see the artificial vessels is around here and no bubbles outside the artificial vessels. So this is good for the patient, and this is only the hematoma outside the artificial vessels. These two are common celiac artery, and this is aorta. This is the color Doppler we can see here is a hypoechoic. And also it is the same with the CTA scanning. There's no contrast outside the artificial artery. After the EVA, there's some common complications, including the endoleak of stent and stent thrombosis and stenosis. And also the stent is sometimes can be twisted or displaced. As we know that, according to the position of blood flow in turning, it can be divided into 4 types. For type 1, type 3, and type 4 are about the has some relationship with the stent itself. And type 2 is blood flow from the abdominal aorta branches to the tumor cavity. As we know that the type 1A is from the attachment of the end of the stent to the cavity. It is from the proximal end to the cavity. But for type 1B, it's from the distal end to the cavity. Now let's see a case. This patient is 65 years old male patient. He has abdominal aortic aneurysm and bilateral common iliac artery aneurysm. After EVA, there were type 1A, type 1B, and type 2 endoleaks in this patient. In this picture, we can see this is the type 1A from the proximal attachment. This is type 1B from the distal attachment. This is type 2 from the inferior mesenteric artery to the cavity. And also it is the same with the CTA scanning. This is type 2. This is type 1A. Now let's see the video. We can see here the bubbles just came out from the proximal attachment to the cavity. This is the stent. We can see the bubbles flowing very clearly, and the bubbles goes into the cavity from the beginning after the injection of the contrast agent. And this is the type 1B of endoleak. We can see the bubbles goes into the cavity from the distal attachment of the left iliac artery attachment. So this is the left side of the common iliac artery. This is the stent, and here around here, this is the cavity. So this is the type 1B endoleak. And this one is the type 2 endoleak. We can see the bubbles goes from the inferior mesenteric artery to the cavity. This is the stent, and this one, this artery is the inferior mesenteric artery. So as we know that the contrast agent can help us and to find the endoleak. Now let's have some tips. As we know that when we do the scanning, we should of patients suspected of abdominal aneurysm, we should avoid overpressure when examining the large aneurysms. So, and the second, we should know the details of the patient after operation. And when we want to find the source of the leakage, we should find it by including the injection of contrast agent repeatedly and combining with the color Doppler flow direction. It can help us to do the correct diagnosis. Thank you very much.